I will officially welcome everyone. Hello, I am Joan Devine. I'm the Director of Education with Pioneer Network, and this is your official welcome to the virtual learning circle portion of our current, it's actually the 5th Listen, Learn, Explore educational program that we've had. I hope you got a chance to listen to and enjoy the podcast that Laci and Natasha did. We're very excited to be gathering together for more exploration of pay for performance and the toolkit to help state policymakers promote person-centered care. The goal of this session really is interaction and engagement to really further explore the topic and an opportunity to talk with Laci and Natasha. And I think they're going to have a few other guests that may be joining us as well that can share about the work that they have been doing. We encourage you to turn on your cameras if you have it. If not, we understand that's okay too. So everyone's in our virtual, as they call it, our virtual circle of squares is what we have here. So a number of ways to participate, certainly typing in the chat. We welcome you to do that, using the reactions on your toolbar if you'd like to use those just to give us a quick feedback on something. And then of course, absolutely joining in on the conversation. And to do that, you can just raise your hand, you can unmute yourself and start talking. You can just, we'll be informal. We've got a nice square. As of right now, everybody's in it. So we should be able to see each other. At the end of the conversation, you'll get a link to a short survey to give us a little bit of feedback, and we hope that you will do that. And so that's enough of the business. I would now like to turn things over to Laci and Natasha.
Hello, everyone. Welcome. And we're excited that you're interested in the toolkit for a number of reasons, but largely because it means that you're dedicated to person-centered care and advancing it further in your states. I thought I could give you just a brief recap of some of the podcast information, just so you know that. Natasha and LeadingAge, the policy side at UMass, did some research with Peak 2.0. So she's on hand to talk or answer your questions about that. And then Georgiana Correll from the Kansas Department of Aging and Disability Services is also on the call, and I just want to thank her for being here. She is here to answer questions about from the state's perspective, because it is a KDADS program. And so Peak 2.0 is an incentive, Medicaid incentive. And it is built into the Kansas policy, and it was initiated to because there were folks at the state level who really wanted to see person-centered care be the norm in our state. And there were a lot of people that were standouts, but they were very few in number. And they wanted to see it gain traction across all the homes so that all of the elders in Kansas could benefit from that. And so they built that into the incentive when they moved to managed care in the state of Kansas. And so that's where we are today. And we would like to answer, part of having the listen and learn is to answer your specific questions after listening to the podcast. So I would like to just open it up and hear what you want to know.
I have a question. Can you tell us more about what's in the toolkit?
Yes. Well, I'm going to share my screen real quick because I think some of you may already know how to find the toolkit, but I thought I'd give you a little rundown of how to find it on the main LeadingAge website. And so the first thing you do is, go to the main LeadingAge website, and then to find the Policy Center, go to Centers, that tab, and then you'll see LeadingAge LTSS Center at UMass Boston. And so, get back here. Okay, so then go to the resource library, if I recall. Yes. Okay, great. Natasha's helping me out here. All right, so this looks different than the way I practiced it, Natasha.
I think if you go into the LTSS Center and resources.
Okay, so center, Oh, nursing homes, maybe. That's how I got
Well, we
it.
also have a toolkit section, but
Okay.
that will get you there as well. There it is, second one.
Here we go. So here's all of the research that came out of PEAK. Okay, so that's not the toolkit though. We got to go to the toolkits. I got thrown off by the resource list here. We're trying over. We should have had Natasha do this. So I'm gonna, you know how you have to just take a pause and step out. I'm gonna show you from the PEAK website how to get there.
Okay.
Then we'll go back to the LeadingAge website. So the best way to get to the PEAK website is to Google PEAK 2.0, and it's the first thing that shows up. And then if you go under Person-Centered Care Resources, there is a button for research articles, and the toolkit is the very first thing there. And so this is the full toolkit. And this basically talks about the key things in the toolkit are why person-centered care is important, and then giving you basically a case study of how Kansas got it built into the policy to make it an incentive program. So it talks about working with the state, why it's been successful, because there's some components within the program that have made it stand out from other pay-for-performance programs. And so if you're considering trying to advocate for it to be in policy or a pay-for-performance program, I think it's important to look at what are the aspects of this program that have made it work well for people, because just getting it as an incentive isn't necessarily what's helped it be successful or helped it to work for homes in our state. There's some aspects of the program that have been pivotal in that. And one of them is that there is a structured definition of person-centered care. And so that's talked about in the toolkit, but if you're kind of wanting the short, quick way to find that, or you haven't looked at that, it is on the website here under criteria. And there's just a plethora of resources that are free and available for homes to use. And so the criteria really walks through the structured definition. So there are 4 domains, and then within those are the core practices. So it would be things like food and sleep, and then some specific outcomes that for homes to be successful with implementing person-centered care according to the program, they need to meet. So for example, it would be food being available 24/7. So it's a structured definition we all know, or we become more on the same page. So that's something that's been pivotal to the program. And then there's a lot of feedback and support for homes as they navigate the change. We know that this is a big organizational change, and it's not just relabeling something. And so homes need that technical support as they walk through that change. And so that's something that this program also offers, and it's progressive. So it doesn't just reward the homes when they've done it or the outcomes happened. They're rewarded along the way for getting education, even though it's a smaller incentive at that level, but then also for implementing. And then as they're starting to demonstrate results, that incentive becomes more. And so it's not just at the end when you're done. We know that this process takes a while. It's along the way as well. So those are some of the really key features that have helped the program be successful. Minnesota also has a pretty successful pay-for-performance program. It's not specific to person-centered care, but it's on quality, and it has some of these also characteristics as well, as some high levels of technical support, more immediate types of rewards attached to things rather than that real delayed process. And so as you work with policymakers, I think these are some characteristics that are in the toolkit that can help you really make a big impact if you're able to get it put into policy. Okay, there we go. Look at this.
I knew it was under resource.
I know, I just couldn't get to this page. I think my internet was lagging was the problem. So taking a break worked. So when you click on that LTSS Center at UMass Boston, typically this is what shows up right away. And then you go to that resources, and then there's nursing home toolkits. And then it's just right there, and you can download it from there. So easy peasy. Sorry it didn't work the first time. That's the way it goes.
Thank you.
Yeah.
Laci, I love what you shared about having intermediary goals throughout this, because I think that's so critical for people. It's so hard to see that long-term outcome and to wait for that. And I think we lose people along the way because they don't have the patience for it, especially if you're trying to help somebody who doesn't necessarily believe in everything that you're doing, to be able to show them that you are making progress, that, you know, they don't have to wait for that one big win at the end.
Well, and people don't feel like they can waste all of that time on education. And this is so helpful. I love it. I just love it. I've always been a big fan. And I just confess that I have not listened to the podcast first. So I was going to do that, and I got a phone call. So I apologize for but you guys and Natasha, you guys have all done a really excellent job on the toolkit. I've read the toolkit. And I'm looking forward to this criteria, because that's a way to help you make your points when you're trying to be an advocate to get this going in a particular state. But one thing I really wanted to ask, if it's okay now in terms of our timing, Joan, you tell me if this is okay for now. Okay. Is how in Kansas did you guys navigate? Did LeadingAge did the LeadingAge in Kansas kind of lead this initiative and get it going? Or how did you get the LeadingAge and the Healthcare Association working together on this? And, you know, for example, the Healthcare Association has their own bronze, silver, gold thing. Yes. You know, quality improvement types of things that are written into a lot of pay for performance quality incentives in states, as well as the JCO kinds of things. What is the best way? How did you all help switch that narrative to now we also need to have something that's focused on person-centered care?
Yeah. Well, I can give you kind of historically how it came to be. Now, this came into policy in 2011. So it was kind of, I don't know, those bronze, silver, etc. awards weren't quite as mainstream then. So it was kind of before that. Now, in Kansas, how this initiative got going was PEAK existed before it was a pay for performance program, but it was just an awards and recognition program. And the Kansas State University, which is where I work, wrote education modules on person-centered care. And it was kind of early in the process. But, that initiative didn't get as much traction as we wanted in the state as far as people really significantly making changes and not just the innovative homes, So this initiative kind of started from within KDADS. And so there were a couple of champions at the state level who were instrumental in getting it started. And Dave Halferty is one of the people who was in the fiscal side of things. He worked at KDADS at the time. And then Sean Sullivan, who was a long-term care, yes, go ahead.
KDADS is what?
Sorry, Kansas Department of Aging and Disability Services.
Okay, sorry.
Yeah, sorry. Too many acronyms, right? So, and Sean Sullivan ended up becoming the Secretary on Aging at the time. And so he kind of started the discussions around it. But then what happened was the idea was we want to get an incentive going. And I wasn't intimately involved in this process, but watched it kind of from the outside because I had just kind of started work at K-State at that time. They got a whole variety of stakeholders together to develop that criteria that exists for person-centered care here. And they're not new, they're evidence-based practices. They're what, the literature says, they're the practices that are important there, but there was a whole group of people that included the associations, included ombudsmen, included some providers, included some of the team from K-State, and they really looked at what are the things that make person-centered care, and develop that criteria. The criteria has been sort of honed over the years, but it hasn't changed drastically. It's some of those things that when we look across all the different kind of models, if you think about greenhouse, households, the values of person-centered care that Pioneer Network has, they're the systems, practices, the on-the-ground things that help support person-centered care that are evidence-based in literature. And so they adopted those. And then Sean and Dave really led some of the initiatives on the state side to get it put, into actual policy and in the state plan and structured on that end and get the money going for it. And that sort of thing. So the piece here is that this comes alongside of other quality initiatives, and maybe Georgiana could add something here. So it's not the only incentive that homes can get in Kansas. There are also incentives that are related to more general quality things that some of those programs that you talked about, Kim, encompass, things. Yeah. So it is a part of the total incentive package. It's
so
not
homes can do multiple things. They can choose for quality of care, you can do this. And for quality of life, which is also written into the rules and regs, you can do this, right? Yes. Okay.
But what's interesting, and Natasha can affirm this, that's where we got engaged with LeadingAges to really evaluate the program, both in terms of quality of life impact and clinical quality impact. And this has actually improved clinical quality too in homes that have adopted it at a high level.
Yeah, so that's the role of LeadingAges. We weren't involved in initiating or getting the program implemented. We came in as outside evaluators to determine what is the impact of this program. So one of the things we did look at it were who were the adopters of the program. And we did find the early adopters were those innovators. They tended to be not-for-profit organizations, part of a CCRC, had higher occupancy rates, and also had higher quality measures. But as the program progressed and you had the financial incentives, you brought in more nursing homes being part of Peak, and then they came to more represent the state of the nursing homes in Kansas, and you got more of the for-profits into adopting the Peak program. And then we also looked at, is there any impact on the quality of life and the quality of care of the residents? And I think a key component is that the program is comprehensively adopted. So where we saw the impact was more in the later stages of adoption of the Peak program and person-centered care. And in those, we did see some of the depression and other clinical measures where we saw improvements in those that had comprehensively adopted the Peak 2.0 program compared to those that had not adopted or were not participating in the program. So it got to show the robustness of the program and that you really can improve the quality of care for the residents.
Which
But
is
I think one of the
so
things we see in
important.
the literature, I'm sorry, is that often person-centered care is not comprehensively adopted. So I think that's a key part, is that you're actually taking all the different components of what makes up person-centered care and adopting those. And outside of the Peak, one of the things we've seen in the literature, like workforce empowerment is one of those elements that's not always adopted by the nursing homes.
Awesome. Thank you so much. That's such important research for us to have, to be able to use in different ways. So thank you.
Yeah, I mean, I think if you can show that you can improve quality, that this might be worth an investment to at the state level.
Exactly. So that's good, depending on who you're talking to, what you the different tools that you use, explain why everybody needs to be paying attention to this.
Exactly.
Yeah. Any of the other, since person-centered planning has been so written into the rules and regs for home and community-based services now, and it's required for home and community-based services, has anybody, or have you all done anything to try and put something like this together for the home and community-based services areas within the state?
It has not gone that direction at this point, but it's definitely something from within that we recognize. It's not just nursing homes that need person-centered care, it's across the continuum, because I think there's an assumption that because we're offering that service in the home, that obviously it's directed by the person, and yet yeah, I'm seeing head shaking. We've seen it happen where there's some really medically modeled home health, even assisted living, across it all, that there's work to be done there. And I think that there's definitely translation of some of the work that Peak has done that can translate there. And I thought, just because this is a good way to kind of share some of the tools and how they can be used. And I think you can adapt them for that if that's something that, that you're actively working in that environment and looking for, man, I see this as a need, that you could use some of the stuff that's here and translate it to that.
I just see that would be so helpful for all these states. CL has everybody working on these different group projects to come up with their definitions of person-centered care and planning. And it feels like it'd be a great time to try and figure out, Natasha, from a LeadingAge perspective, perhaps how to translate this for, all of the non-nursing home venues.
Right.
Yeah.
No, I think that's a great idea. I mean, I think we certainly do at LeadingAge a lot of work across the Continuum because we represent the full range of providers, and certainly in home health care, while it might be more challenging environment, doesn't mean the need isn't there, and how you then take tools that are available for the nursing homes and translate and make it adaptable into the home health care environment.
Yeah.
Also assisted living and
And
also
assisted
adult day
yeah.
services. Yeah.
And one
Oh,
of the things I know that can happen is, we have person-centered care. We can kind of look at it through a couple of different lenses, and where Peak focuses, and what I've appreciated about Pioneer Network over the years is it's not just the individual to individual level, how we interact with people, which is important. That part's important, and we can provide good person-centered care, person to person, but it's also the system, how
absolutely.
the system either enables person-centered care to happen or how it disenables it. And Peak really looks at breaking down those systems that challenges our ability to offer person-centered care, and comes in and says, this is a system, we have to change the system to better support individualized services. And that needs to happen in other venues. And so I thought I could just kind of take, when you talk about person-centered planning, which is such a part of PDPM, that patient-driven payment model, one of our areas kind of focuses in on that person-centered care planning. And I think it can so easily be translated outside of the nursing home. And it's this core 4 under resident choice domain. And it's about residents deciding how they spend their day. So here are the practices or systems that help us get to that goal, right? And so first is, it starts right at move it. And this is like right at intake, with home health intake is gathering information about routines and preferences prior to people moving in. So a lot of times it's, we go out and screen people before they come, but we're looking for that clinical nuts and bolts information, but we're not asking simple questions about, what's important to you, what makes you you. Like
we're looking at the yes, no on the ADL, IDL assessment.
Yes. What's,
that?
what
more
are
or whatever.
Yeah. So then, it's one thing to collect information, but then what do you do with it, right? So then it's the next piece is caregivers have access to the information. So once you have this information, how is it shared with caregivers prior to the move-in, if possible? We know there's emergency, day of types of things, but even day of, you can get the information to caregivers as quickly as you can, right? And then supporting those daily routines from the start, right? Not after you've done all of the assessments and then on day 3, because that's 3 days of experience that your caregivers have had and that elder has had and their families had. So let's try to start from the beginning with, the things at least that are most important to that person. We aren't going to know everything about them because that takes time, but all of us have things that are really important to us. Like for me, it's, I need to eat and have a cup of coffee before you'd ever get me in the shower, because I have kind of low blood pressure just on a general basis. And if I get in the shower first, I get the little sparklies and the I'm gonna pass out thing if I get in a hot shower first. So you gotta put food in me, get me some water and coffee, then shower, right? So that's important to know about me before you take care of me, even before day 1, because otherwise I'm gonna end up on the floor in the bathroom, right? So some of those little things that make us tick, right? So then moving to the care plan development, it's about, this was written before the rules of participation were put into the regulations, but 90% of care plans are attended by residents or family. And we really educate. There's some additional materials in the Peak stuff called core considerations, and they go into more depth about what this means, but it goes beyond just coming to an actual meeting around the table. It could be conference call, it could be, Zooms, whatever. So different methods of participation, but 90% of residents and or family are at the actual care plan. That they're participating in the creation of the care plan, not just told what's on the care plan and what the goals are, that they're participating in that. And then 90% of the care plans are attended by direct caregivers.
Yeah.
Yeah. And
So what year did you say? You said this was before. So what year were these done?
2011.
Okay. Okay.
Mm-hmm. So this actually, homes that had advanced in peak and had done this were ready for the rules of participation and were far more advanced than homes that hadn't. Not just rules of participation, but in general, they were more prepared for the regulations when they came out. So, and then in regards to the direct caregivers, some people implemented the actual regulation where caregivers would write notes on pieces of paper prior to the care plan, but they didn't actually attend it. They didn't actually participate in it. And through peak, we really talk about having direct caregivers in care plans for those elders that they are actively taking care of, right? So we talk about, getting the structure of the care plan, potentially relook at that structure to where the first part is really, we've got a direct caregiver in here and their role is to really answer any of your questions about the day-to-day of your family member or the elder, or the elder being able to talk about how the day-to-day stuff is going for them and what's working well and what isn't, so that it's direct kind of communication to the person that's most directly taking care of them. So they may be in the care plan, for the whole care plan, but it may be the first 10 to 15 minutes to really address those. Okay, we're getting that day-to-day picture of the elder straight from the person that is generally taking care of them, right? And then care plan delivery is all the caregivers have access to the care plan information, that they have a system available to communicate changes to the care plan. So that they can say, this isn't how it's actually looking for that resident anymore, and this is what it should actually say, kind of thing, and that there's a good feedback loop for that, not just every 3 months, but on an ongoing sort of thing. And then this last one's really that the care plan's actually person-centered. And we don't require care plans, but we're looking for, if I'm reading the care plan, that I could tell that this is an individual person and couldn't just be any resident at a nursing home, right? It's actually got some personalized. So anyways,
It's
that's
not copied out of a template.
Yeah, exactly.
Yeah.
And there are a lot of that out there, although we've seen some improvement in that. So that just kind of walks you through one of the areas, but each core has elements like this, and then we have some resources that go with it. So like the core considerations there's one in each of the criteria. So if we go to that direct daily routines, it just talks through some of the things that I shared with you that are kind of beyond the criteria. It includes some of that stuff there to give homes a better idea. It's kind of like, you have the actual regulations and then you have the further guidance on it. It's kind of like that, but yeah.
Like the interpretive guideline.
Yes, exactly.
Okay.
Only better.
Yeah. Hopefully more straightforward. But we also have audits. So one of the other unique things about this program as an incentive than some others is that there's some accountability built in. Because there's money attached to it, what we find is when we ask people about how they're doing with person-centered care, a lot of times their assessment of where they're at and what's actually happening is different, right? And so we actually yearly evaluate every home on the specific areas they're focusing on. And so.
And who is we? That y'all at the university, right?
Right. That's a good question. That would be we have a team here at Kansas State University. The Kansas Department of Aging and Disability Services, or the state, contracts with us, Kansas State University, to do the work of this program. And so we have a team of people, and they are not university professors. I
Right.
am the only one based at the university that has kind of an academic background. The rest are actually practitioners or have had lots of experience in nursing homes. And they are the ones that do the education and evaluation of homes. So,
And I'm sorry I'm hogging all the questions, but in terms of the education, who chose education, Laci? Was it the modules that you all had created that you were continuing to update and fix? You education, but other educational offerings be added that would fit and work with peak?
So actually we've abandoned using the modules in that they were, they're great information, they're foundational information, but it takes a lot of work to continue to update those education modules. So it's more about taking that information and making it tangible and live for people, because honestly, not a lot of providers are going to go read a 30-page module. It's just not realistic, right? So it's about making that information live, and it's really about staying current with research and practices that are out there, best practices, what we learn from other people, what we learn from Pioneer Network. We use an awful lot of resources from other people to integrate into things, but it's all about supporting and bringing to life how you could actually implement the practices and the criteria. And so we do that in a variety of ways. We have a year of education and training that is the very first level of peak, called the foundation. And that's where homes go through a year as a team. We do a lot of actually building into the requirements, having more than just the leaders, the appointed leaders in the organization involved in the education, right? So we require that direct caregivers are a part of that more than just the administrator and the DON or whatever are part of those. So we do regular Zoom meetings that have little snippets of information that are a part of that. And then we do a mentor home training. So we actually have some of the homes that are in the upper levels of the program. And we have those listed out here. So these are some of the homes that have comprehensively adopted and are mentoring others. And there's a lot more that have implemented all of them and are working on mentoring. But so the people, the homes in the foundation bring a team to one of these homes, and they get more specialized training in the criteria from us. But then at the same training, they're actually in the home, and they spend an afternoon or a morning in the home observing and being kind of matched up with somebody in a peer in a similar position as of them, so they can see it in action and what their role would be, and then in this different way of doing things.
That's so great. So how did y'all adapt that during COVID when they weren't actually physically able to do that? Right.
Well, that is the one thing that you can never replicate as well. So we'll just be flat out honest about that. But what we did is Pete kind of went on a dormant phase for a while because KDADs wanted homes to be able to really be able to respond to COVID. But we were able to start that back up. And when we did it, we did Zoom and we did breakout rooms with mentor homes. And so we would have a breakout room for each of the domains, like home environment, resident choice, staff empowerment. And we had mentor homes that led those conversations and talked about how things work in their home. So they talked about liberalized med pass and where they keep the medications and how that looks, and there'd be discussion on food and that sort of thing. But it's just never the same as actually, it's one thing to hear that it works, but it's a different thing to actually watch it and see how residents respond to it. So
Laci, kind of on the same, I'm sorry, Kim, I'm going to jump in here a second.
Good.
the kind of on the same note with the past year and everything that everyone has been through, have you been able to see, are you able to validate in any way the positive outcomes, a correlation in positive outcomes with those communities who were very engaged, who are those upper level, the mentor homes, and have you seen a correlation to their quality outcomes because of that fundamental foundation that they have through this program?
One thing where we saw real differentiation, and we're actually starting a research study on this because I don't know if you saw the greenhouse. I don't know that it's come out fully yet, but looking at greenhouses and the mortality rates due to COVID, the differentiation there. We're replicating that study with our peak homes because we anecdotally saw that, the homes at these upper levels that you see here, they're in households, small groups of resident, no more than 30, and they have consistent staffing. That's a requirement to be at these upper levels. And so they weren't immune to getting COVID. But what we saw is that these homes, if they got COVID, it didn't spread to the whole entire facility. It had a chance to be contained, say, in one area, and they did not have the devastating deaths that some of the homes had where, there was just a difference there. And so we're kind of validating all of the different intricacies of that, hopefully, but we anecdotally definitely saw that.
It's great that you're researching that because that's what I had been wondering, because I knew there was no research around household model or anything that other than greenhouse, and that greenhouse study was wonderful. And it's really important because people, even, in the news and everything, all they hear about is greenhouse and that model, but we also know about the household model, which is similar. But we don't have any outcome studies around that because I know that we got in touch with Action Pack to see if they did and they didn't. So it's so important to have that research done. So thanks for doing that.
And I think, Natasha, maybe this is a leading age question with, this evidence is going to be so powerful as we move forward. The fact that you put this toolkit together specifically addressing to policymakers. So have you seen interest since you put the toolkit together in different states, in different organizations who want to embrace this? And do you see it as something that can add value as we are, as a nation, looking at how we provide healthcare, how we provide services to seniors? Because it's finally on a platform now. People are talking about it who never talked about it before. So are there opportunities there that you have seen and interest?
Yeah, we've heard from folks that they're interested, but taking it to the next step and actually getting it put into place in your state is a whole different level. And we certainly are very fond and very much like this program. I think it has some unique aspects that we don't see in other culture change programs. I think the financial incentives, I think what Laci talked about, the assessments, which we really like, of seeing what is actually happening in the nursing home, because even outside of peak in our own research, we hear providers say they're doing certain things. And then when you actually go into the nursing home, you see it can be very different than what they think is happening. And so I think that is a really key component of this peak program, which we would like to see other states adopt. Certainly how we get that, we're trying to get it out to our state execs who can then influence their state policymakers and making them aware of the toolkit. We certainly have promoted it in that way. And I'm hoping as states and nursing homes sort of move from COVID, which I think is right now a lot of our focus of our state executives, that they can start looking forward and how they can improve the culture of the nursing home. Because we know that the nursing homes have been hit even more so during COVID, and their reputation and what people think of nursing homes. And so, this could be a tool of making more of a person-centered care nursing home and how you could differentiate yourself from others. And we're also looking, while we haven't seen the green model, what is the difference between the nursing homes that did have the higher mortality and infection rates compared to nursing homes that didn't? I've seen some studies that it does relate to the nursing home compare, but others was really the communities and where the workers live, because they would tend to bring in the COVID from their community into the nursing homes, or working multiple jobs. So I think there are a lot of opportunities for us in working with, I think, our state execs, and how we can get more states to adopt PEAK or a similar type of program.
Well, and
Natasha,
Natasha, I'm sorry.
This is
Sorry.
Georgiana. Can I ask a question real quick?
Yes.
Or I
go.
don't really ask a question, but I wanted to kind of just throw out some information. So I don't know with what, Laci, while you're doing this study, if it would be helpful or beneficial for you to be able to see which nursing facilities set up a alternate care site, or a designated facility or unit, or a change in bed classification for COVID isolation and preparedness, if that might help you also. I think that that's a good measure also to at least look at, to see, since you are seeing some variance in the mortality rates and things like that. I think it would also be helpful for you to know what facilities specifically set up what in preparation for that.
Oh, I'd love to do that.
Okay, so
Deeper dive. I'll get with you.
Okay, great. So I will send that to you. Okay.
Perfect.
All right,
Thank you, Bill.
That's great.
You're
I
welcome.
wanted to say, Natasha, I'm thrilled to hear about your promoting it, the toolkit and advocacy for this with your state execs, because we've done this for a while, but didn't have a toolkit, which is why I'm so thrilled about the toolkit with the State Culture Change Coalition. So Kim is with the Georgia Coalition, Denise is with the Nebraska Coalition, as well as the Eden Alternative. And having this toolkit is great, but also, and some of the LeadingAge affiliates are involved in their coalitions. In fact, in Georgia, they helped start the coalition and are involved. So, and in others, they're not. But if this would be a way that the state culture change coalitions could work with their LeadingAge affiliate in their state, that would be great, because the coalitions don't have the lobbying power that the provider associations have, but have a lot of knowledge about person-centered care and a mission to advance culture change and person-centered care in their state. So that would be terrific.
That's perfect.
If you find, as time goes on, after the COVID stuff and everything, that there are certain state execs that are very interested in pursuing that, we would love to know, so that if there is a coalition in their state, we'd love to connect them if they're not already connected.
Okay. I think as we do have a state exec network, and we can start. I'll be honest, we haven't done as much direct promotion of it, because we kind of know now during the vaccines and a lot of issues right now are taking up their time, but certainly looking to do more active promotion of the toolkit and seeing who's interested. And then I can connect with you guys if there's certain states that really do want to take it to the next level.
That would be wonderful.
There's a lot of work to be done. So I think that, but I think it obviously has to happen at the state level. And I think the state execs could be a stakeholder in that process.
Yeah, and if there's a coalition of organizations in that state, that would be great, that it's providers, maybe consumer organizations and others, so that policymakers will see it's not just so-called the providers, but there are all these stakeholders who don't always agree, who may be agreeing on this, which I think is something that could be, because consumers too want person-centered care to happen.
Right.
Anyway, we'll see.
I do go back to, and you can show through the research the positive outcomes of adopting this type of program.
Yeah, the fact that you have those outcomes is really valuable. Thanks so much.
Yeah, I can't wait to read
I'll
that.
springboard off of that for sure, because I think in some states in Kansas, we have a more moderate balance of for-profit and not-for-profit, but there are some states that have a lot more for-profit than not-for-profit.
Right. Yes.
And I think that that's a different kind of sell and support for the for-profit sector. And we've learned a little bit about that through PEAK. And I think that some of those states, and just in general, as we look at trying to get person-centered care more mainstream, is that PEAK has contributed some to being able to really anchor why this is of value to for the for-profit world, and part of that is the research that, Natasha and her group has put together on that clinical and that outcome. But we've also done the business case for person-centered care that includes some case studies that, you can use to kind of help talk to those groups of people. And then, we often run out and hire consultants for various different initiatives, and that costs a lot of money. And I think that those are very important assets. But the other thing that this program can kind of help with for-profit is there's some like mainstream stuff out there that's at your disposal to use, and so I think that within the getting it into policy, but also just in general, pushing it out there, these are things that can help get us past that bubble.
That's a great point, Laci, because 70% of the nursing homes are for profit. So
yeah, exactly.
That's a very important stakeholder group. If we really want to see widespread adoption of the PEAK program, you're only going to get a select group with the not-for-profit nursing homes.
Exactly.
I have to give credit to Dr. Linda Hermer, who did a lot of the research and is no longer with LeadingAge, but she did show over time that more for-profits were adopting the PEAK program.
Great.
Where is that, Natasha?
We have a couple peer-reviewed journals. I don't know if there's a way to get it out to everyone, but I'd be happy to share some of the articles that have been published. Dr. Hermer looked at sort of the adopters versus non-adopters of the PEAK program.
That would be great.
They're all on our webpage right here.
Are they all on their webpage?
Oh, good. Wonderful.
Because they're in journals that you may have to have like a subscription or something to. And so we put the PDFs up here. So they're all accessible.
Great.
Yep, they're in this person-centered care resources, and then they're under research.
That's awesome. In Georgia, Natasha, I worked, Walter Coffey and I co-founded Culture Change Network of Georgia together. And that's why I started by asking the whole question about, when the healthcare associations really trying to push their own quality incentives, I've been scheming on how to help balance, how to champion this in the state and get it added. So I'm so excited about these other articles and ways to think about how to present this to different key stakeholders.
Yeah.
Excellent.
Oh, what a great conversation this has been.
Laci, do you have any other, are there any other do you have any other states that are doing the same thing at the university level that you all are doing? Because you guys are really carrying a huge role in the, the day-to-day and the running and the implementation. And have any of you all looked at how a CMP might help fund something like this?
Well, I'll have to leave the CMP specific question to Georgiana to give you anything that's misinformation here. But my understanding is CMP funds at the state level are kind of handled differently state by state. And so in some states, the opportunity to use CMP funds would be pretty great, like they'd be good, and others not as much. In Kansas, certainly there's a pool of funds there, but they aren't used maybe in the same way as they are in other states. And so in our state, that pool of money maybe wouldn't necessarily work for this, but in another state, maybe it would. And Georgiana, you can chime in there if you want to.
Yeah, I mean, our CMP, I know that we use ours for specific reasons, and we have to actually get approval from CMS to use some of those CMP funds as well, depending on what it is. So I know that we have not looked at using CMP funds in the past to support peak, but I know that, you know, Laci and Tracy and myself have been looking at some other alternatives, maybe outside of peak or maybe within peak. You know, is there any way we could use any CMP funds or anything else that we may have, some other type of fee fund that we may have? So at this moment, the answer is no, we do not use that. But it doesn't mean that that can't change potentially in the future.
Maybe just even nationally looking at it more like a national CMP, like from the innovation level, Natasha, something like that.
Yeah, I think CMP's at the state. I'll have to say I'm not an expert on that one, but I mean, that's why I think we did the brief in the toolkit for policymakers, thinking that this may have to happen at the state level, but
Yeah.
certainly thinking about other opportunities.
I think that's a start of a really good conversation though, Kim, because there are funds available nationally that, I mean, there are
That's what I'm talking about.
There are federal surveys that occur and there are kind of penalties that come from that. I don't know what kind of pot of money they have around that, but that could still be a conversation to continue as far as.
I'm thinking national CMP, there's national and there's state. And I'm just thinking nationally that looking at it, like if we're trying to kind of champion in several different states to get it going, to promote life, to drive culture change, it could just seems like they'd want to do it.
That's a national demonstration project that was,
Yeah.
That was part of it. And, you know, it's something that could be brought up to CMS as an interest, you know, something that they might want to fund in the future.
And I just because we were part of the application process, but just didn't get funded. But I know Mayor Rothschild Foundation is also looking at how you define person-centered care. And I think they're also looking at a national effort for that and having criteria.
And is that part of the current project that was funded in Maine, or is that something separate?
I think it's separate because this was at the proposal. I think the work is just starting.
Okay.
I just saw something come through on it the other day.
Okay, Joe, good.
One of the other things that I think is important to the conversation is the regulatory environment and how that's looked. Generally for nursing homes is very punitive in nature, with not a lot of support for how to fix things, you know?
Yeah.
And so that has been, I know, something that like Carmen Bowman is really interested in, is sort of changing the dynamic of how that survey process looks, because if we really want good quality homes, it's not just about penalizing them for doing wrong. It's about, you know, providing them what they need to be successful, right? And so that's one of the things that I think there's been kind of a shift in the culture here in Kansas, at least with this program, is homes aren't used to that. Like they get evaluated from us. And initially it was like, you're just dinging us, you know, you're just dinging us for things. And it's like, we really built in a lot of layers of feedback to the homes to not only show them, you know, what practices are in place and what aren't, but also, you know, we see these gaps, but how can we move to that next level to get better and to improve? And
we're paying you to get better instead of finding you.
And we provide training and technical assistance.
Yeah, exactly.
Yeah, all of that sort of thing. And so I think nationally, you know, whether, you know, not just peak in how it looks, but nationally, I think that that's what we need to see more of in any programs that we implement for homes, is not just showing where gaps are, but how do you close the gap and improve quality and get better? Because that only helps all of us, you know.
And from a PR perspective, after all the bad press from COVID, now's a great time to be thinking this way.
Yes. Yeah.
And I know LeadingAge National is looking at nursing home reform and maybe how does person-centered care fit into the reform efforts that they're promoting to try and improve the image of nursing homes, particularly after COVID. But I know that's something that they're looking at as well.
I mean, the policy document that LeadingAge did about the changes that are needed in the system was wonderful. You know, even more so than the one that was done with AHCA, with the American Healthcare Association.
Yeah,
we really we agreed with a lot of what you have in that document.
No, that's No, I think our policy team is really doing a lot, and how seeing this, I think, as an opportunity of changes we can make, whether it's nursing home, the workforce, in many different areas for aging services, because all the bad that came with COVID, there are opportunities, I think, with the attention that's focused on our field right now.
Mm-hmm.
I also see how this could be layered and tied in with the next step being a dementia version of PEAK, and how all of this could tie in to the way that we're all trying to think of how to build workforce in terms of, you know, lattice, layer, you know, all the lattice, crosswise, you know, when we're trying to people's role in the workforce, this is another great tool to have as part of a conversation at this level with the key policymakers. I could talk about this all.
And I mean, and that's, I think, one of the things I love about the PEAK program is the valuing of the direct care professional and their input and being part of the care planning process. Because I truly believe they're the eyes and ears and they see things. And I think they have a lot to contribute and aren't always valued as part of those conversations. And I think that's really another great aspect of this program.
Absolutely.
Well, this has been, we are actually 2 minutes over the hour and still going strong. It's been a wonderful conversation. I know, Laci, you have shared so much with Pioneer Network over the years and about the PEAK program, and this is certainly one more incredible opportunity that has come from it. And Natasha, the partnership with LeadingAge has been wonderful to see, and the opportunities, you know, as they say, don't waste a good pandemic. So we have opportunities right now. And I think this is one of those opportunities. So this conversation is being recorded and it will be on our website. So anybody will be able to go in, they can see it, they can still watch the podcast. So if you know people that you want to be a part of this conversation, that they should have been a part of this conversation, send them the link once it's up and invite them to participate. The other thing I did mention at the beginning, Kathy's going to pop in the chat a link to a short survey, because we'd love to know how we're doing as we continue this Listen, Learn, Explore series, one of our new endeavors in 2021. And we do have we got a couple more Listen, Learn, Explorers in the queue. So watch the Pioneer Network newsletter and social media sites. The next one's going to launch May 5th, so next week. It's going to be Spring is Here, time to reconnect with Mother Nature with our good friends from Comfort Tech. So that should be a great conversation, and a couple other great ones coming up too, but I won't spend a lot of time telling you that. I also invite you, Kathy's going to put a link, because, you know, I have to do this. She's going to put a link to our events page. So check it out. And lots of things we're adding as we go. We're doing a lot of education that's kind of developed more just in time this year, because we know people's needs. We have definitely seen in this last year how much they've changed. But we are getting ready to launch our next symposium, which is going to be Envisioning the Future, Dementia Care 2021 and beyond. If we stick to our target, it'll be launched by the end of this week. And I invite you to take a look at it. We've got some truly dynamic speakers that are going to be a part of that, and a wonderful opportunity for conversation. And there's nothing better than good conversation. So thank you again, Natasha and Laci, and all of you who are a part of this. and looking forward to wonderful things yet to come with this incredible program. So thank you.
Thank you so much.
Thank you so much, Laci and Natasha,
Thanks, everyone.
Yeah.
and everyone
Bye-bye.
else for coming.
Thank